Terus ya merik, Mbak. Di Vietnam? تعال ننام هنا اقعد هنا. شاطر ماشي. يلا. باص. هتنام ولا لأ؟ سيبه هو هيتصلح.
Hello everyone. Thank you once again for logging in to this, our first of the Best of QADS webinar series. A few housekeeping items. If you have any questions or any comments at any point throughout the presentation, please feel free to enter them, type them into the questions part of your GoToWebinar control panel, and our speaker will address them after his presentation. And also, if you haven't already, please visit sunnyclear.com/webinars to check out the other webinars in the series coming up in the next few months. So without further ado, let me introduce our speaker for the day. Okay, our speaker is Dr. Eric Klein. He's Vice President and Director of Medical Physics at Northwell Health System, and he has an adjunct appointment of professor at Hofstra University. Before that, Dr. Klein was at Washington University for 26 years, holding leadership roles such as the head of the Proton Project and director of the Medical Physics Residency Program. And Dr. Klein was chair for the QA subcommittee for the AAPM and also task group chair for TG142, which has now evolved into TG198 and an implementation guide for TG142, but you'll hear more about that in the presentation. So Dr. Klein, thank you so much for taking the time to present today. Please go ahead and begin.
Thank you very much. Good afternoon or good morning, depending where you are. Through the course of this presentation, I do have questions that come up that were used originally for SAMS type questions, but I left them in the talk so to point out some of the highlights of the lecture itself. So let's begin. And it's kind of an odd term to say what is missing in the TG142 guidance, but when I get toward the end about things that were not included strategically, and then I think will make more sense. So we need to just recap about TG142. Historically, TG142 was created as a stopgap because TG100 was belabored and didn't really go over technical performance issues, but rather how to create a QA program. We'll talk a little bit about that later. So TG142 filled in the gaps from that, from basing a TG40 onto what is now known as TG142. So that distinguishing aspect comes into play about when you talk about methodology. So TG142 really focuses on performance base, where quality is evaluated and with expected results and with leeway for tolerances and recommendations for frequency of testing. So it by no means takes a scientific approach about building in such things as FMEA to figure out which tests really mean something, but rather is done by consensus. The task group was composed of physicists in academic facilities, physicists at community hospitals, and a few consultants from both delivery systems and measurement systems. So, and part of the philosophy of TG142 is to not so much make a monthly review something you have to do by the 31st of the month, but rather something to prove that the quality remains of what your machine was started off to be in expectations. Process-based looks at processes and performance with ever-evolving feedback about how to evaluate what's important in terms of spending time on quality assurance. You may also notice as continued quality improvement. So if we look back and further in time to TG40, which is still a living document because it's still the scope of TG40 was not just on medical accelerators, but rather on other types of machinery, even including brachytherapy, so it predated TG56 and TG59. Also, it predated TG66 on CT simulators. So at its time, it actually was a very comprehensive a guidance document, and including roles of physicists, roles of radiation oncologists, roles of dosimetrists. The key aspect that people looked at, of course, was the QA of medical electron accelerators, which has now blended itself to TG142. So again, TG100, which still is in development as a draft on the APM website, was originally thought to be a replacement for TG40 based on FMEA, failure modes and effects analysis, and it is still evolving today about how to build a QA program based on FMEA and other types of statistical analysis in terms of what has to focus. So TG142 then filled in the gap between TG40 and TG100 with performance-based recommendations. So we replaced actually one large table in TG40, became the essence of the TG142 report, and that table 2 of TG40 was basically QA of accelerators in terms of the type of test and the frequency of testing and the tolerances. It did not, even in 1994, include anything about asymmetric jaws, the wedge systems that are now available in all machines, MLC, special procedures, imaging, and of course gating. And again, this is circa 1994. So the philosophy of TG142, other than just making recommendations, is to build in a little bit of TG100 philosophy. And therefore, the type of treatments that are done may require different criteria in terms of accuracy. For example, high-dose per fraction SBRT or SRS is certainly, because of the high-dose per fraction, it's more critical that the performance of the machine be up to snuff. Also, again, TG142 looked at machines that do different things, such as doing IMRT or total body irradiation and total skin electrons, etc., and have unique criteria for those type of machines that do those certain activities. So one of the quirky things, of course, is that how does a report remain a scientific report and not become law? So TG142 is never intended to be used by regulators at law. So we put in italicized, we put it in a box and said the recommendations are not to be used as regulations. These are guidelines for the qualified medical physicists to use and develop their own QA at their own individual institution, which of course things such as time requirements, etc. may be one facility may differ than another. However, the real regulators did look at this and did use the parameters as a guideline of what should be done. So states that have agreement states where licenses are given to facilities, but so the regulators did look at it anyway. And I guess because they really have no other basis to go on other than scientific reports, and I guess we're glad that they at least look at the reports if they don't just happen to use them verbatim. Other things that were very different. So there was a confusing aspect, at least most of us in the task group felt, that the definition of flatness and symmetry fell a little flat, if you will, in TG40 because they allowed for this plus or minus 3%, which could mean theoretically that you could have a 6% change in your profiles and still be okay in terms of symmetry. And also, of course, TG40 did not have, at that time, even the notion of how to handle flattening beams without flattening filters. So TG40, instead of putting in hard numbers to look for on a monthly basis for flatness and symmetry, rather the philosophy is that you look at your beam profiles. Now, beam profiles give you a lot of information. They tell you about symmetry, they tell you about flatness, but as flatness is a very sensitive measure of energy because of the flattening filter, then if you've used these measured data that you took during acceptance testing and commissioning, and you feed your planning system that information, and then it spits out isodose maps in a phantom at first, and then used for patient treatment, then the key is that the profiles remain consistent, even if they weren't perfect. That those profiles are the standard for which to compare against. So instead, as you'll see more descriptive, we'll look for constancy of profile, not so much hard numbers to look at. So we're looking at a consistent beam profile, and that being key. We just see some examples here of a profile taken at likely the Dmax depth, and if that's what you happen to measure, these are quite nice, and that's what you fed your planning system, and that's what we're looking for. And sorry about this getting cut off a little bit. The other thing that TG142 did is it set the user with the ability to set action levels of when something needs to be dealt with. And actually, if you read TG142, and most people don't read TG142, just let's be honest, most people look for the tables and go with those tables, and as they study for their board exams or they set up their QA program. But actually, if you read that through this interesting passages that talk about things such as when do you do an inspection, when do you just schedule something, and when do you have immediate action. So to break that down a little bit, if the famous question of what happens if your morning output measures 4% off. So that would be, is that a scheduled action to take care of maybe when the day is over, or is it immediate action? And the answer, of course, it's immediate action. Or if your output is consistently 2.5% off, maybe that's not an immediate action, but maybe that's a scheduled action. Or if suddenly you had a rock steady machine and suddenly it went off by 3% on a given day, then you may do an inspection at some point to make sure that your measurement system was correct. But anyway, this is detailed well and hopefully utilized by users as a way to think about what to do if, and setting up criteria for these actions. So again, as we want to sort of phase out the thoughts of TG40, here's just a table that shows the differences. And one thing is that every month physicists were taking out their water scanning systems to measure energy, quote unquote, by use of percent depth dose measurements. Well, TG142 removed that based on the fact that if your flatness profile is as expected, then you've checked energy and you're done. You don't need to bring out your water tank. Electrons, again, using sort of gamma criteria with 2% or 2 millimeters for constancy of depth dose. And again, the monthly parameters TG40 for flatness and symmetry for photons and electrons is every place with a constancy goal of 1%. Things where people were checking interlocks on emergency off systems every month, which means that they're 12 times a year they were being tested and probably never used otherwise. So instead, these again are based on experiences that show that a lot of these tests that were being done were actually futile or taken care of by other means. So it's just again a comparison table between the two. All right, so this question that was used in regards to profiles, TG142 recommends the following criteria for monthly reviews. You can look at your answers, but I hope that everyone would pick A. That recommends that that the profiles are consistent with commissioning profiles to within 1%. Okay, so to look at now a view of what happens on a monthly basis. So now we have, and independent of the type of machine that you're using or what you're using it for, whether it's non-IMRT, IMRT, or SVRT, the flatness measurements for that given machine just have to be consistent. Other things that were looked at, and something that was pointed out, is the value of percent depth dose of 10 centimeters. So if once a month you bring out your ADCL system to measure output, or your field system to measure output, and you have to, so according to TG51, make your measurement at 10%, 10 centimeters depth. So if you do that and you do comparison to the dose at D max, you then measure percent depth dose in 10 centimeters, reasonable way, and if you find that you're plus or minus 1% from your baseline, then you really don't need to measure percent depth doses. Okay, so that was a hard thing to swallow because physicists were used to measuring percent depth doses every month. And in fact, annually, if your percent depth dose is within plus or minus 1%, is there really a need to do percent depth dose scanning? Same thing with profiles. If you're measuring profiles every month and they're very consistent, do you need to bring out a water tank to do profile scanning? And the answer is that's totally up to the physicist. What TG142 tries to teach you, or had tried to teach you, was that you could probably, if you can justify it, show you don't need to do water scanning provided you've made at least one measurement for depth dose and your profiles have been consistent. That's a very difficult thing for people to grasp. So, according to TG142, for a dual energy machine, percent depth dose must be measured on an annual basis for, and here's your choices, and the answer is D, all energies, but it's not necessary if the percent depth dose at 10 centimeters depth is within 1% of criteria. So we all know that 18 MV would be 80%, or 6 MV would be 67% on almost all machines. So if that's within 1%, your depth doses don't necessarily have to be measured. Now, as new technologies are added to our accelerators, so does the quality assurance of these new additional devices. And so here's where we can break down the criteria of the types of testing. If it's not an SRS SBRT machine, then the criteria that was suggested is that you have an accuracy of positioning or repositioning of 2 millimeters, where if you're performing SRS SBRT, again, very high dose per fraction, but that have a tighter criteria of 1 millimeter. Here's a difficult test that's a bit controversial, is your coincidence of imaging and treatment isocenters to be within 2 millimeters if you're doing non-SRS SBRT and only 1 millimeter for SRS and SBRT. So the reality check is performing those tests, you have to be very careful with your measurement system. And if your table couch system has any play to it, getting to 1 millimeter coincidence could be very difficult. And that's expressed down here in terms of the coincidence of the two different systems for either cone beam CT or for onboard imaging. So again, this explains the functionality differences of the two. I want to go back. No, sorry. Okay. So regarding TG142, for the coincidence of machine beam isocenter, radiation beam isocenter, and imaging isocenter, the values are different. Are they the same or are they different? So here's again your choices of answer. And the answer is C. So C being 2 millimeters for non-SRS SBRT and 1 millimeter for SRS SBRT. So even habitually now, I'm talking about these as being requirements. And again, these are not requirements. Every physicist has the ability and capability, this is what TG100 will help with, to develop their own QA program in terms of a variety of different things, in terms of how much time they have and prioritization and what criteria is expected, which even goes back into talking about things such as margins. If you're developing margins for PTV or ITV based on expectations for a machine, and that machine for some reason isn't meeting this criteria and you loosen your criteria, it may mean you need to increase your margins. So this is what we're getting to. If you look at the difference of delivery and planned, and you look up setup accuracy, it's again quite difficult if you're looking at setup accuracy required for, let's say, a treatment of the spine or a treatment of a lesion, adjacent to the spine and so forth. So anyway, this is studies that are done that looked at how do you maintain a level of accuracy for given types of treatment. So anyway, so TG142 came out in 2009. It actually was fairly fast track because it really didn't start until 2007. But nonetheless, in 2009, the manuscript came out, and there were some questions that were a little confusing or even controversial. So, and this is part of the problem of what's missing in the TG-142 report. So going to a consistent profile, what does that mean? And that means going back to the commissioning and treatment planning validation data. And the profiles taken at those time are what you want to try to maintain. One thing, because we did this by consensus, so sometimes we make compromises, laser localization accuracy of 1.5 millimeters. Well, on hindsight, that was probably a little mistake. People couldn't agree whether it was 1 millimeter or 2 millimeters, so we split the difference. But can you really measure 0.5 millimeter accuracy? Also at that time, when we were developing this document, we were trying to get a good handle on accuracy of MLC positions at a given instant during IMRT delivery. And not all manufacturers had the same thing in place in terms of criteria. So what we did, because at least for a lot of the people on the task group, it was tested and tried and true, especially if you look at dialog files, to use the varying criteria of root mean square errors, which is what we had ended up doing. People have a tough time with the congruence of photon imaging isocenters, again, because it's thought to be unrealistic. But anyway, but the problem is if you loosen it to 2 millimeters, are you then building in more uncertainty on a daily setup, again, for these high dose per fraction? So these are things that still are a bit confusing or controversial. Again, as I mentioned before, the regulators took this document verbatim in many states, but also the people who help us out in looking at our QA programs and our delivery accuracy also decided that they were going to expect QA programs to be based on TG-142. Sorry about the colors on this, but the RPC, now known as IROC Houston, which does on-site dosimetry reviews for NCI-funded clinical trial institutions, implemented TG-142 as the guidelines that people should be using in developing their QA program. ACR, basically, this may have been updated since, but it clearly points out, if you look at a number of things, that it points out that TG-142 and TG-40, depending on what system you're looking at, is there compliance. So ACR site visits, and maybe some of you in the audience, I know I myself have gone on site visits for ACR, and now I'm going on Astro, and it's so surprising that there are a number of things that are not adopted yet by TG-142 suggestions, particularly related to imaging and gating. And again, not just ACR, but Astro. Astro has a standard section that looks at the QA program, and that should be consistent with AAPM or equivalent body standards. And then, again, then always keep in mind, too, that TG-142 really just addresses linear accelerator-based performance technology, but also there are other things in TG-40 that show up in both the ACR and the Astro Apex views, such as how physicists are involved in QA meetings, how downtime is recorded, how service on machines are recorded. Those things still fall into TG-40 rather than TG-142. And the same way that people criticize TG-40 coming out and not addressing even simple things like asymmetric jaws or MLCs, which at that time jaws had been around, asymmetric jaws had been around about 5 years and MLC about 3 years, and yet TG-40 didn't address them. But there is timing of things. Manuscripts like this, comprehensive ones, aren't written overnight. They take months and months and months of building consensus and going through a review process. So the same thing with TG-142, which came out in 2009, which is just about the start of RapidArc, SmartArc, VMAT, etc. Same thing is that this transcript report doesn't deal with tomotherapy because it has its own QA report, a very excellent one, TG-148, and the same thing for robotic radiosurgery, aka TG-153, also has their own QA recommendations. So TG-142 did not need to cover those particular modalities. The task group didn't address FMEA because that was taken care of by TG-100, which started in 2004 and was expected to have a report in 2006, then 2010, then 2014. And now in 2016, there is a draft on the APM website which everyone can look at. But again, in the meantime, or coinciding, TG142 does have, and tries to read this very clearly, is that it is really on the burden of the physicist to read the report, and from that report, take their suggested tolerances and frequency of testing and build your QA program around those recommendations. Again, they are more of shoulds, not shalls, and it gives guidance. So and this will fall in with TG100, which does allow flexibility for a given physicist or group of physicists at a particular facility. And there's a lot of work right now going on statistical process control, which basically examines frequency of testing to determine ways about hopefully reducing activities or frequency of testing based on results. And this is typically a living process in finding out what type of tests have been futile and which have been very important. And that helps guide. And there's, again, a number of papers that have come up from the Duke group and other groups that use statistical process control as a way of monitoring their QA system and adjusting it essentially on the fly over the course of time from making measures. The other thing that we were very careful about in TG142 was naming specific methods for making measurements, and especially not making any note of commercial products. This is very tempting to do, even putting in diagrams or pictures of things. We decided not to do that because we didn't want to condone any system over another. Something that, even the most subtle of instances can lead to indirect recommendation. So that that's why, and we talk about TG198 in a few minutes. So physicists were left with all these new tests to do, the addition of imaging, the addition of gating, and yet there was no recommendation about how to make those measurements, and more particularly what tools to use. So what's next? TG198, an implementation guide for TG142. And that's just what it is. And the intention of TG198 is to be a living document that gets updated over time. But it does make subtle recommendations, not any particular commercial products, but how to make the measurements. So for example, and also pay attention to something that's a bit pet peeve of mine, this is the recommendation of TG198 for daily QA. So it takes right from TG142, lists the tests, depending on whether they're dosimetric, mechanical, or safety tests, and it gives you recommendations for the measuring device. Again, without particularly naming any particular vendor. They also give, and this is where people have to be careful, a time required to make these measurements. So this, of course, it talks about setting up your equipment and everything. But some of these to me seem just a little bit inflated, but it all depends on your system. But here's an example of what TG198 is doing, and it's very close to it. It's putting out its first product, and it will be revised with longevity as some of the information gets fed back about some of the recommendations. So here's an example of daily imaging QA, and some of these are very common sense. A lot of things that are done on a daily basis for imaging can be done with a simple phantom containing opaque markers, and that's those cubes, if you will, come with different machines, and they have embedded markers strategically set up in a particular phantom for testing of imaging. And again, you can see some of the time requirements for making some of these measurements. And these are good guidelines because when you justify staffing, and there are a couple of publications out about staffing, and that talks about how much time, and you can put in how many plans you reviewed, and how many basic patient chart checks you do, everything. And QA has to be its own separate line item. And if you collectively think that it takes you now 2 hours to do a monthly, how do you justify that 2 hours? And administrators are getting, of course, tougher and tougher nowadays. So this helps a little bit in giving some guidance about how long it really should take or can take to do routine QA. Here's just the monthly TG198 recommendations, and again, this comes from TG142. And again here, hierarchy of measurements for monthly rather than daily. And so again, it gives you the test, and the tolerances are in TG142. It gives you then the recommended equipment, what to do, and for various things. Some of these things, again, are very obvious. And again, it gives time requirements, and so why I don't want people to take these time requirements verbatim. Whatever it takes you to do really should be how you enter in and validate and justify the time that you're putting in. Some of these just seem very, very extensive, and even some of the tests. So even though I'm on TG198, I'm not liking the way that the estimates are going. I think people have to be more realistic and not exaggerate the time it takes to do things, because there are tools to be built that are built by vendors that can make these type of tests very, very, very efficient, especially now analysis tools. And Sun Nuclear puts out a great analysis tool test, taking from measurements and giving you histories of your measurements and real-time reviews of things such as MLC accuracy. Monthly imaging QA, again, very simple requirements. The requirements from TG142, and also the types of tools to use and the time required to do such tests, which again, if you've not done this before because an imaging device is new to you, this can be quite handy in helping give you guidance of how long to plan for and in total to just how to justify staffing and such. MLC QA, the TG142 recommends a qualitative picket fence, which can be measured with an array. Most people do it with film, but a portal imager, and that being a very quick test that gives you a lot of very important information. Then some things, by the way, in TG142 I didn't mention are very specific for the manufacturer. The way Electa handles MLCs and their design with the backup diaphragms is very unique compared to a draw replacement system or MLC additional system. So some other things too, very quirky about the fact that Siemens electron beams are calibrated with a different system in terms of monitor chamber systems, so therefore the idea of doing electrons only once a week may not be sufficient for that type of system. Anyway, there's lots of things here with guidance about what tools to use for MLC measurements and how long it typically takes to do, and that can depend on the system that you're using. So TG198 will give the suggested hows, which again, TG142 didn't say how to do things or what tools to use. TG142 was designed to partner with TG100. Until 100 becomes a real document, though, there are things in TG142 that can help you in deciding on frequency and intensity of testing. And the ironic thing is, and I'm on a task group 224 for Proton QA, and we started off with, as our template for thinking about what things can be tested, by using TG142 and at least the draft TG100.
Amen.
So at least
Amen.
in some ways, when something comes up, for example, if someone wanted to develop a QA program for an MR Linac screening system, then how do you start building your QA program? Because you really don't have enough history to know, by consensus, to come up with testing methods or tools. So instead, looking at what TG142 offers may not be a bad way as a starting point, or TG100. So this is happening as new technologies still continue to bombard us, which is great. It keeps us employed and keeps us active.
Okay.
So with that, I'll finish up and be happy to take questions.
Thank you so much, Dr. Klein. I'll give you a chance to go ahead and pull up that questions window. And just a reminder to